We have a distinct faculty today. Dr. Gaurav Ailawadi from the University of Michigan, Dr. Bill Brinkman from the Heart Hospital Baylor Plano in Texas, Dr. Mark Moon from Washington University School of Medicine in St. Louis, and Dr. Viv Rao from Toronto General Hospital in Toronto in Canada. And my name is Peter Kapitein. I'm Vice President as Chief Medical Officer for Medtronic. So, as discussed, we want to discuss these difficult cases. And Dr. Brinkman has one that he likes to share with our colleagues here and discuss what they would do if they would encounter a similar case in their hospital. Dr. Brinkman.
Thank you, Peter. And it's an honor to be included with such a great group of surgeons. I really appreciate that. And I appreciate Medtronic facilitating this. My case is a guy with a clinical issue, which is probably managed well with surgery or with endovascular therapy. But the challenge is figuring out which way to go in today's world. You know, it's a difficult clinic conversation we all have every day. 64-year-old guy shows up in clinic, shortness of breath, dyspnea, no chest pain. And he has an echo, which we see here with heavy calcification on the long axis view. His mitral's working quite well. And he has severe, verging on critical, but not quite critical, severe aortic stenosis. The mean gradient is over 40. Peak velocity is above 400. And he has a bicuspid valve, at least that's our feeling on the CT and the echo. History of hepatitis C, used to live kind of hard, got treated with oral therapy, and his gastroenterologist assures me that his liver function, synthetic function are good. So really a child's A kind of situation. Quit smoking about 5 months ago, had a small squamous cell excised. He's not a fat guy. He's reasonable size. BSA is 1.94. So he had a left heart catheterization, as you see here, which really just shows only very mild luminal irregularities. So, you know, being the surgeon, I started kind of moving him towards SAVR. And I think the people on this call probably would. I think the data are good with our approach to that. But the interventional cardiologist in our heart team will say, well, wait a minute, you know, he's low risk bicuspid. Let's look at the calcium on his valve. Let's look at the characteristics that might make him good for SAVR versus TAVR.
So Bill, I agree with you. I think this is a very common scenario we see in our clinics all the time. And I think technically they can be done either way, as you mentioned at the outset. However, what we're moving to now is looking at the lifetime therapy for this guy. So we would look at his age and say, regardless of what we're going to do with the tissue valve, whether it's SAVR or TAVR, he's looking at a second intervention in his life. So with the comorbidities, we got to decide, is he going to survive long enough to get to a second intervention? In which case, I think you would probably favor SAVR followed by a valve-in-valve TAVR. If you think that his comorbidities limit his survival, then I think it's reasonable to proceed with TAVR now. Well, what do my colleagues think?
Yeah, I'll add, I think your point, Viv, is absolutely true about starting this discussion now about what the next aortic valve procedure will be like. You know, presuming you start having that discussion based on their age. So I don't ever really think about age in an entity by itself. I think about what's the life expectancy of that patient. And I think we will get smarter over time. There are going to be better life tables, for example, like the STS. We have a risk calculator for their 30-day risk. Hopefully we'll eventually be able to develop a risk calculator just for survival. You know, there is data, you know, for patients over 70 that undergo an aortic valve replacement, the number of patients that reach another valve operation is exceedingly small, at least when it comes to conventional surgery. And so that whole paradigm is shifting, but we just don't know. You would think a 64-year-old with even with treated Hep C should outlive this valve. And I think it's important at this stage right now when he's in clinic and amongst your heart team, talk about what's the next procedure, not just this one, but what's the next procedure that they get. I would also argue that the cardiologists, although that we've had great results helping them with TAVR in a bicuspid, those are the publications are really in a very select population of patients. It's not really in all comers. And so I would love to see what the calcium looks like, what the pattern looks like, what type of valve choices we're thinking. Certainly if there's large burden of calcium that's near the in the outflow tract, what's the rupture risk? If there's calcium close to the AV node, what's the pacemaker risk? I think those are probably important elements before jumping into TAVR.
Let's go to the next slide, and that has some.
Well, let's stick with that one for a second, because there was a paper in the Annals just this last month looking at liver function and survival, and these are patients who did not have normal liver function. This patient obviously does, and there was about a 15-20% decreased survival in those that actually had liver dysfunction at a year, 3 years, and 5 years. But I think in this patient, we sort of say, oh, his STS risk is 2%. Well, I would say to this, realistically, this guy's got a 0% operative risk. This healthy patient, this isn't, when you talk about the all-comers, Gaurav, the all-comers is what determines the 2% risk. And that 2% risk is, the somewhat frail patient that's debilitated. This guy sounds like a completely healthy patient. Unless there's a catastrophe, this guy's risk is 0%. So I think putting operative mortality risk into the equation is really not right. So that's why I agree with you that we really need to look at his long-term outcome and what's going to be best for his long-term outcome. And we know that with the TAVR, and I heard my cardiologist saying this yesterday to a patient in the Cath lab, you will have an increased stroke risk, increased perivalvular leak risk, and an increased pacemaker risk. And if you put that all together, that doesn't sound like a good equation. I don't know. What do you think, Bill?
Yeah, it's a similar discussion. Then we always start talking about embolic protection and all these issues.
Hey, Mark, who's your cardiologist? We got to get them to work for us.
He's actually given a presentation at the meeting. I'm not going to tell you which one, but you can find him.
There you go. That's a smart man. You are.
Yeah.
So maybe let's go to the next slide. I just want to show you the characteristics of the valve. There's some, yeah. So no, one more. Yeah, perfect. So you can see the area, the perimeter, and the average diameter. These are things we consider when we're considering TAVR. And I also like to think about them when I'm doing SAVR. This information really helps me go into the operating room with a great plan. So I think, getting a 25 or a 27 might be a challenge. And I think with a valve-in-valve, it's a consideration. Patient prosthesis mismatch, all that sort of stuff later we can talk about. You can look at the RAF-A, which is significantly calcified, and there's the non-coronary larger cusp has significant calcium, but there's not a lot of calcium at the LVOT. This is one where the cardiologist might say, this is a good one for TAVR, even though they don't really know that for sure. They'll say that. And then the ascending aorta is mildly dilated. It's less than 4. So what do y'all think about this scenario?
So I'm also curious what you think about this amount of calcium, that it's heavy in certain areas, for TAVR. Bill, you do a lot of TAVR as well, right? So,
yeah.
Let's change the scenario. Let's say this patient is high risk for whatever reason or doesn't have longevity. What would how comfortable would you be doing a TAVR with this calcification pattern, this anatomy?
I think I would actually be pretty comfortable with it. It's the hockey puck. We call it hockey puck calcification heading down the LVOT in the aortomitral curtain, which really catches our eyes. And I don't see that here. We've had very good results short term. I think the pacemaker rates are probably a little higher. We haven't, in a male, we haven't had annular rupture be a problem. It's usually the frail older ladies where we've pushed that RAF-A, I think, through the aortic wall. Mm-hmm. So and we've done
Does valve choice play a role? A balloon expander versus a self-expanding. I know we typically choose a self-expanding in this scenario if TAVR is the right option.
Yeah, our bias is probably towards self-expanding in this scenario, but we also would use embolic protection in this scenario too. We'd use a sentinel device in the innominate and the left common carotid.
Gaurav, I think you brought up a good point for TAVR. We always look at the aortomitral curtain. So if the echo report comments on severe MAC in conjunction with a bicuspid aortic valve, I think that raises a red flag for us. So, and I think Bill commented on that, the extent of the annular calcification that projects downward into the LVOT.
Yeah, and the other thing I look at is just the bulk of the calcification on the leaflets themselves as that gets pushed out to the wall. Maybe not so much for rupture, annular rupture, but for pacemaker risk, particularly if it's.
What I'm seeing here on Bill's case is that I don't think our cardiologists have any trouble with this amount of calcification.
Yeah. So the question is, it can be done technically. The question is, what's the best long-term, as was alluded to by, you earlier. I mean, and that's a discussion I had with the patient. And we presented various options, one sort of a minimally invasive upper hemisternotomy approach with root enlargement, possibly, versus SAVR, versus TAVR. And that's a discussion. We also discussed the various types of TAVR valves and SAVR situations with him.
I'm curious, Bill, I don't know if you went down this far with the patient or your heart team did. If you did a TAVR, what was the discussion about? What would the next operation be? Would it be an open or would it be a valve and valve?
Yeah, what do you think of durability in this particular patient? Would that be an issue?
Do we know what the durability is?
Peter, you got to tell us that with the Medtronic.
That's what you're supposed to tell.
But
I think Mark hit the head right there on the nail, that we don't really know what the durability is beyond 5 years, especially in a bicuspid young man with some, hepatic disease there. So this valve could easily fail in 6 years. And now he's not looking at one intervention in his lifetime. He might be looking at 2 additional interventions in his lifetime.
And the second intervention many times is a full root if you have to go back in there after a TAVR. I think that's what we've encountered. There are situations where I've gotten away with just peeling that thing out, but a lot of times you're doing a full root.
And maybe Peter can comment on it from Medtronic data or the other panelists, but I think, at least in our group, it's becoming increasingly recognized that a second valve in valve is not a good thing to do. The gradients are just unacceptable. So someone would come in for a one valve in valve, but if we're planning on a third intervention, like right now, we would say surgery now, one valve in valve afterwards. So what do you guys think about a double valve in valve?
Yeah, I think that would be acceptable, isn't it, Viv? Because if you get a surgical valve now that may last, let's say, 12, 14 years, well, then this patient is now 64, so that brings him to the end of his 70s, and then you could do a valve in valve. And maybe a gradient will be a little bit higher, but maybe that's not a major issue at that age of 78, 80 years of age.
What size valve do you guys think you'd want to get in there to minimize the gradient? I mean, would a 25 be good enough? 23 be good enough? What
I wouldn't
size
accept a 23. I think you need a 25 minimum on this guy.
Yeah,
knowing that you're coming back for a valve in valve.
His BSA was 1.9, right? So we're going with different criteria than we did when we were just looking at a straight surgical valve, because probably a 23 and a 1.9, it would be okay. He'd be asymptomatic with that, but like you said, if you're going to put a valve in valve inside of it, you want to get an even higher.
And Peter, I'll just plug the TGH data. If this guy gets a Hancock, he's got a 90% chance of going 20 years with that valve over age 60. So again, it depends on the valve you put in. But a Hancock over age 60 has excellent durability, and it may be the only operation this guy needs.
Yeah, I think that's a good point that Mark just made. If it's his last, if we have good confidence that it is his last operation, then you maybe don't need to push to get a 25 or larger. But certainly with that plan in mind and all the discussion we've had and probably the discussion you had with the patient, I think you're obligated to, if you can do it safely while you're in there, enlarge the root and get a bigger valve.
What I hear is the consensus is surgery, Bill. Is that what you? Yeah,
and I kind of, that day in clinic, there were some more junior cardiologists, so I kind of strong-armed them, and we went to surgery. No, I'm just kidding. No, we have a very good heart team in our hospital, and that's and I'm sure these other hospitals do too, but that's really been the best thing to come in recently in our clinics. But we had a real good discussion. The patient was fine with either way. He was going to go with what we recommended.
Hey, Bill, I'm curious if you tell the audience a little more specifically, when you have your discussion, is it in front of the patient together, or do you have it in the back room and you go in and say, this is what we think?
Well, we sit in a room and go over the films together, and we kind of have a general idea, but like in a guy like this, low risk, bicuspid, our bias is towards surgery, and the cardiologists realize that. And unless we see something unexpected, like, oh, well, I got radiated for Hodgkin's when I was 15, that, and that with cobalt,
But I think Gaurav's asking whether the two of you go approach the patient together, or is it a representative of the heart team? And to answer your question, TGH, we make the decision behind the scenes, and then whoever actually brought the patient forward, go back to the patient and said the heart team consensus was to go forward with option A. So we don't go to them as a group and say, here's 7 different opinions, and what do you think?
Yeah, so I certainly heard what you're saying, Viv, where people go in, the two teams that might have surgeon and cardiologist may have already had the discussion in the back room, but they go in and they say, here's the benefits and risks of both approaches, help the patient make the decision that they want.
We take it a little bit more expanded out approach, because we've got 3 different valve clinics with 6 different physicians, cardiologist and surgeon in each of the 3 clinics. And so we don't usually give the patients a final answer at that clinic appointment. We have those 3 days a week, and then on Tuesday mornings, we review every patient that came in through the valve clinic, and so that the entire team sort of comes up with a plan. Then we call the patients afterwards, unless it's a straightforward thing. Obviously, sometimes it can be decided right away, but I don't know if that's the right approach or not.
Well, yeah, we go in the room together, and it's kind of a long clinic, but we have a general idea where we want to take the patient, but we're not the most efficient clinic, but I think the patient leaves there with a clear plan. But I think all those are great ways of doing it. Yeah.
How long does it usually take, Bill, to the discussion with the patient?
Well, it depends on the patient, but it usually probably I'd say around 15 minutes, we can get the discussion done. But some people are more nervous, and you might be in there a lot longer, and then the rest of the clinic gets upset, Yeah.
Right.
What's your experience with your patients? I'm finding that these days you get 2 groups. They're either the ones that say, I don't want surgery, so please give me TAVR. And then you have to spend a lot of time convincing them why TAVR is not the right option for them. Or like Bill's patient, they're saying, I'm happy with whatever the team decides is best for me, and you just make a decision and tell me which way I'm going. I've yet to see a patient who says, I want surgery no matter what.
Yeah. So what's the percentage now, Viv, that comes with a clear opinion?
I think in my practice, about 20% are trying to avoid surgery. And the vast majority are, you guys are the experts, you tell me what's best for me, and I'll go with whatever you decide. There is the odd patient, I'll take that back. There is the odd patient that says, I don't want to think about my valve anymore. So, especially when they're approaching 70, and they're saying, if you're telling me that one operation is all I need, give me surgery and I'll be done with it. And they don't want to think about coming back for something else when they're in their 80s. So there is the odd patient that favors surgery, but I'm going to say the vast majority are willing to go with whatever the heart team decides.
Would that patient be a mechanical valve patient then, Viv?
Yeah, I was just going to ask. Yeah.
I mean, it's hard to say that you're only going to get one operation if it's a tissue valve.
Yeah, again, we just show them our data. So a 70-year-old having a Hancock valve, now granted, some of those might have needed surgery when they're 90, they didn't get it, but certainly from our echo data, 90% freedom from SVD at 20 years. So it's pretty good that valve's going to last them the rest of their life.
Yeah, I probably put in 2 mechanical valves last year, I would guess.
I can't remember the last aortic mitral valve I put in, except for maybe an endocarditis in a 30-year-old.
Yeah. Was that an option, Bill, a mechanical heart valve that was not at the table?
Well, over 60, the history of the hepatitis, we didn't really discuss it much with him. But I think it's a consideration. If he was younger than 60, we would have just considered it. But our bias is, over 60, we don't even really discuss it with him usually. Right.
Yeah, that makes sense. I mean, I hate warfarin. I hate it. The patients hate it. It's bad.
If you're younger than 60 and we think your survival is greater than 15 years, we're going to probably bring up mechanical. We'll bring up Ross also. We'll talk about various aspects.
Well, I put countless tissue valves in 25-year-old patients, not because they didn't want to take warfarin or it's going right in, but I look at these guys and I know they're not going to take their warfarin. I've got kids that are 25. no way would they take it every single day. So I mean, I think our use of the tissue valve is far more extensive now than it was even a decade ago.
Yeah, right. Shall we go to the next slide?
We have the same conversation you do, so it's very similar about Ross versus mechanical versus tissue. I'd say we're probably putting in more than two valves a year. We're putting actually a decent number in the younger patients.
Yeah. So which valve did you choose, Bill?
Well, we chose the Avalis.
Right.
Not just because I'm on a Medtronic symposium. No, seriously, that's our go-to valve at this point. I mean, it's pericardial. We were part of the Paragon trial and we're happy with it. Let's go to the next slide. So TAVR we discussed, mini SAVR. Keep hitting it. Yeah. So it's a low risk bicuspid valve. These are the valves we could have put in, with those perimeters, an Evolut, 29 Evolut, 26 S3, Accurate, Portico. These are all valves we have in our clinic. Some are available, some are in trials. Go ahead.
Hey, Bill, one thing that I think we are all still trying to sort out is looking, TAVR's done a good job of taking a perimeter, an area, and deciding what type of valve will fit in there. And we eyeball it, and we make our own measurements when we're talking about SAVR. Maybe this also gets back to does everybody get a CT scan on every aortic valve patient, even if they're low risk? Because I can tell you there are a lot of places out there that don't. There are people in my own group that don't get a CT scan on every patient. So I'm curious if you think, first of all, is that standard of care, not just a CT of the chest, but like a TAVR CT in a young patient? And have you come up with a more concrete way to make sure you look at a valve, an area that says 450, and you say, I want to get a 25 or a 27, I'm going to have to enlarge the root?
That's a good point. I'd say we don't always get a cardiac 4D CT like we do with TAVR, but we frequently, almost always, will have some sort of chest CT. But I like it when these patients come through the TAVR clinic and we have this information. I don't know what the other guys think.
We don't get a CAT scan on every patient. There goes our profit margin. Especially if it's a TAVR 4D CT scan. Those guys are getting paid more than the four of us. So I just if let's say you're a surgeon who doesn't do root enlargement, maybe that'd be a reasonable thing. So you'd know that you'd have to call your senior partner in there. But nowadays, I think aortic surgeons, it's becoming less and less common to do an AVR, right? I mean, that used to be 4 years ago, that was my most common procedure. Now it's fourth or fifth on the list. So we have to be prepared to do a root enlargement in every patient, I think.
Right. Yeah.
And so if you're prepared, so you know it ahead of time or you know it at the time of surgery, it doesn't really change things too much. It scares a lot of surgeons, but it's really not. It's not that difficult. Actually, it's kind of
pretty straightforward. If you do it fairly often, it's pretty straightforward.
Right.
And to answer Gora's question, we don't do CT scans in everybody, but we do, and I make a point of teaching this to the fellows, is you make a decision about the valve size while they're going to sleep, and you talk to the perfusion, what's their BSA, what's their activity like, and you say, I'm going to put a 25 minimum in this guy. Like I would with Bill's patient here, I would say I wouldn't accept anything less than a 25. Because it's so easy to get in there and you're saying, oh, it's a 23, and do I really want to do root enlargement? And you sort of talk yourself into doing a smaller operation. But when you've committed at the beginning and you got your fellow in front of you and they said, well, I thought we're going to do a 25, so we'd have to do a root enlargement. I said, you're right, we're doing a root enlargement, and you go ahead and do it, the right thing for the patient. So we always make that decision at induction.
Shall we go to the next slide, Bill?
This is really it. I mean,
okay, perfect. Okay.
And so just that's exactly what we did. We decided to do a root enlargement. I thought it was borderline, and he was, so we enlarged his root and we put a 27 Avalis in, and he's doing well. His mean gradient was 5 across the valve a year out, and we'll see how he does. So
Bill, what was the technique did you do in terms of root enlargement? Because now there's some evolving techniques to enlarge.
Well, it's a Manugian style, down through the mid portion of the anterior leaflet. I like to cut in the lips out of a Dacron graft, although some of my partners like to use pericardium. And it's a technique. I remember watching some others. I'm blanking on the surgeon right now who I watched, but Gaudiani. I watched Gaudiani do one.
Right.
I went to California, and I liked the way he did it, so I sort of copied his style, Dr. Gaudiani.
Good. Excellent.
Yeah, I bring it up because one of my partners, Bo Yang, has come up with a pretty consistent, novel way. Instead of a pear shape, he actually makes it intentionally a square. And it's basically makes a Y incision. So just like you're doing a Menugian, except then he cuts underneath the annulus in both directions. And pretty routinely, he can get a 29 millimeter valve. Just about.
Yeah, I saw that article. He
upsize it by 3 sizes. It's pretty
Wow.
impressive. He uses Dacron. And
Yeah.
so he's just got a series of publications coming out about that technique.
That's very cool. Yeah.
Yeah.
I think he's showing a movie of it at the meeting here.
I think he is actually.
I don't remember what day, but it seemed crazy to me when he was describing it over the phone, but it actually
I've
is
scrubbed
pretty.
with him on a couple of these. It's very slick. It's really not a whole lot different than a Menugian, a traditional root enlargement. Just the shape of the patch is different, so it allows a bigger valve.
Are you not afraid? So if the LVOT is still a little bit narrow, then you could put in a larger valve. But do you think that it still has an advantage?
Well, no. At least for a valve-in-valve, no longer is the valve the limitation for the size.
Yeah, correct.
TAVR you'll be able to put in, which it completely wipes it off the table.
Yeah, perfect.
I think we have to move to. We were doing a lot of freestyles and things like that. It's really which one would you rather do? And I think many of the surgeons at Michigan at least have moved away from a freestyle and are using a root enlargement technique like this to get a much larger valve in.
Right. Okay. Shall we go to the next case, Gaurav? You're presenting the next one.
All right, so I'm going to talk about a mitral case and emphasize a couple of the challenges during the COVID pandemic, which I think a lot of us are facing. Here's some conflicts of interest. So this was a 65-year-old gentleman, and I think a lot of the discussion, some of it transpired as an outpatient and then eventually as an inpatient. So he was an outpatient to start, and he'd had worsening class 2 symptoms, not a whole lot of angina, but class 2 bordering on class 3. He had some other important medical history, sleep apnea. He had a history of PE in the past. He had a TIA about a year ago, but no residual defects, no real carotid disease that was noted at the time. History of paroxysmal AFib, particularly after his bladder operation. So the important point here is he did have bladder cancer in 2017, so about 3 or 4 years ago. He had a radical cystectomy and had a neobladder that he has to catheterize several times a day. He was a former smoker, 40-pack year smoker. He quit several years ago. He's still working as a plumber, although with the COVID times, his workload is really lessened quite a bit. And because of that, maybe he didn't notice his symptoms quite as much. He is a motorcycle rider and a hockey player, so that gets into a discussion about a valve choice. That's important. His BMI is 31, so he's about the average Midwesterner. Not like a European, though. So I just want to share this. This was interesting, and I didn't really appreciate this even until after we operated on him, and I went back and really looked at his whole course, because I didn't meet him till January. But he first went to his cardiologist, or went to a doc, and then got to a cardiologist in October of 2020. And at that time, they did an echo because of his symptoms. And he had an EF that was fairly preserved and mild to moderate eccentric mitral regurgitation with prolapse, and they noted some MAC. And then that fast forwarded to the cardiologist decided to get a coronary CT, and that happened in December. And he had a calcium score of 877. It mentioned quite a bit of luminal irregularities and concerning from coronary artery disease. So then in January,
Hey, Gaurav,
yeah.
Why did he do that? I mean, was he trying to find an explanation for this guy's symptoms, or
I believe so. Yes,
okay.
Because the echo really was they thought it was really mild, maybe mild, moderate MR,
Okay.
and the echo clearly probably underrepresented, as you see in the TE. But they were looking for trying to understand his symptoms. And unfortunately, this is well before he got into our system. But So he had a coronary CT again, and then that ended up prompting a Cath, and that I'll show in a moment had 3-vessel coronary disease. And then in February, so then he gets referred to the surgeons and at Michigan, and we saw him. I saw him and ended up ordering a transesophageal echo and had moderate to severe MR with a P2 flail and some MAC. One of the things I want to emphasize, what I put in here with these red arrows is every time he had to get a COVID test, 2 to 3 days before he could get the test du jour here. So in a 3-month time, 3 COVID tests, fortunately all negative. Is this something that you guys are all also experiencing?
Not for the outpatient test. We don't have to get a COVID for an outpatient test, but
for a Cath when they come in, or for a T?
No, only before surgery.
Do you do
it's only surgery for us?
Only surgery. And Bill?
Well, it seems like to go in the cath lab and T's and stuff, they were doing them. So right. I think it's changing a little bit.
Mm-hmm.
Yeah, I guess our practice still is anytime they're coming in for some type of procedure, particularly invasive procedures, Caths, transesophageal echoes, the providers essentially are insisting that, especially like a transesophageal echo, that they're getting a COVID test. Right. It has to be within 4 days. So they have to come in for a visit, clinic, to get the COVID test, to get their prep. Then they come in for the procedure.
Right.
They didn't test me though. They would test the patients. They never would test me.
Right.
Fair enough, but you're vaccinated.
Yeah. Now I am.
Yeah.
How's the mitral annular calcification?
So I'll share with that a little bit. I mean, the report said moderate. So I just wanted to show his coronary disease. His circ was probably the most disease. He'd have a little bit of left main and proximal LAD disease and some right coronary disease. And my overall impression of this is, gosh, his symptoms seem more out of proportion than I might expect based on his Cath alone. And given his symptoms and that he had some concerning of what they said was an eccentric MR jet on a surface echo, and I didn't share that because really I think all of us would have gotten a transesophageal echo ahead of time. I don't think there would have been any question. And I just want to show some of these images and see what you guys think. Obviously, there's a lot of MR and there's a flail. And if you look over here, you get a sense a lot more of what the calcification pattern is going to look like. I'm curious what you guys think at this point of this calcification, and maybe a little more about what the mechanism might be.
Well, I'll jump in there, Gaurav. So for me, there's definitely calcium there, but it's not what I would call the bar of death. So I think I'd go in there expecting to resect the calcium bar and reconstruct that posterior leaflet and then put a Gore-Tex in. However, if we have one of those severe horseshoe MACs in a guy like this who, as you pointed out right at the beginning, doesn't want a mechanical valve or anything like that, and you're trying to repair this, we have on occasion bailed out with not doing any annuloplasty at all and just putting the Gore-Tex in the leaflet with the thought that the calcium bar is basically your annuloplasty band. You're not going to have dilatation of the annulus down the road. And it's worked very well, at least in the short term. So I think you have to be prepared in this case with the amount of calcium I'm seeing that I would probably debride the calcium and do a standard repair.
I might not actually debride the calcium myself. I think in this case, the ring choice is very important because if there's some calcium in the annulus and you put in a rigid CG or contour or something like that, you're trying to force the annulus into a position. Whereas if you're trying to just buttress or repair and you put in a Duran partial band, I think you can do that in a calcified annulus and accomplish what you want to. Now that depends on the level of calcium, but.
So I'll put a plug in for the Medtronic Simplicity because exactly that reason, Mark, is it's basically just a felt band. And so if you have focal annular calcification commonly between P2 and P3, then you want to put the support into the P1 to P3 region. Using the Simplicity band allows you to do that without distorting the annulus at all. So it's a nice choice there.
Yeah, I'm a bit more of a sort of a classic surgeon, so I stick with the Duran anchor. But
so I'll show the CT,
concept.
and then I want to go back to the echo one more time. So this is CT, and you can see it is dense MAC in a very focal area. And it's not a horseshoe by any means. It is really, you know, if you go back to even this 3D view here, and you can see, you can get a sense of where the MAC is. And so I've seen this several times. It's not just truly calcification of the annulus. If you look carefully on the echo on the left and the 3D, you could see the calcium encroaches on the leaflet.
Yeah.
And most likely is the actual reason why the rupture occurred. So I've actually felt like this scenario, putting artificial cords is not going to pull the leaflet down, because the annulus and the base of that posterior leaflet is fixed. It's fixed because there's calcium in, and there's a torn cord. And you could put cords in, but there's going to be a lot of stress on the cords, just like there was to begin with. And it was essentially the MAC encroaching onto the leaflet that made it essentially the cause of the rupture, essentially. And even on the 3D, you can see where that calcium ends. It's essentially right below the tip of that the flail segment, or maybe halfway up the flail segment. You can see that the component that's all calcified.
Yeah.
So in those scenarios, I don't think, you know, just putting a cord in or leaving the calcium alone is really going to ultimately result in a good repair. So it's a subtle difference than MAC that isn't involving the leaflet. I just
completely agree with you, Gorman. I don't want to steal your thunder, but I suspect exactly what you said. It's encroaching onto the posterior leaflet there just before the flail segment. But this is a type of calcium that I think will peel off the leaflet, and once you peel it off, you get a lot more mobility. So I'll be interested to see how you ended up repairing this.
If I repaired
it. Yeah, right.
So during this period, I'll just, I don't know if there are other comments, feel free to weigh in. But.
No, I think that's what we would use, more a classic approach, like what Vivek was talking about, maybe resectional with some cords and a semi-rigid band.
So during this time, so he had, I think at this point, had just gotten his echo. We were working on getting him scheduled for surgery within a week or two. And during that interim, he presented to the emergency room with essentially AFib and RVR and class 4 heart failure, and his BNP had kind of skyrocketed. So he got admitted for diuresis and cardioversion. And I guess now the question is, what would you do? And I think here are the options that we thought about. I mean, medical therapy, PCI and MitraClip with a, you know, more or other tier options and trials. PCI and put them in a TMBR trial, because that calcium, looking at that calcium, it might be a real issue to do an edge-to-edge repair. Probably wouldn't work, and we might find that out too.
So Gaurav, you said something sort of off the cuff that I'm going to bring up, because I think it's an important point, and that is, you know, there's so much pressure these days, especially for junior surgeons, to repair valves. And I tell the junior faculty on my staff is there's nothing wrong with a mosaic repair, because the worst thing you can do is try and attempt a repair in this situation, leave the guy with eccentric, mild to moderate MR postoperatively, accept it because you pat yourself on the back that you repaired the valve, and then a month later he's hemolyzing or he has recurrent flail because you didn't address the original problem. So if you ended up replacing this valve and the guy did well, great job. There's nothing to be ashamed with that.
No, or with a Hancock too. Now, Viv, you were touting up the Hancock in the aortic position, but now you phase shifted over to the mosaic in the mitral position?
Yeah, I tend to like the mosaic in the mitral position. I think, I believe the Medtronic data that the anti-calcification treatment in mosaic is superior to that in Hancock. I'll be honest with you, in the aortic position, I've been a little bit disappointed with the gradients I've seen with mosaic, so I've not put mosaics in the aortic. Very happy with the durability of the Hancock in the aortic position, but we're trying to drum up our mosaic versus Hancock mitral experience, and it's a project we're working on. But anecdotally, I've been favoring the mosaic in the mitral position.
Well, that would be a good study to have. I'll tell you, I put a bazillion Hancock 2s in a mitral position, never have a complication with the valve, and I'll tell you, I have taken out very, very few.
Mm-hmm.
You didn't mention the maze. I figured that's a big component of this too, I guess.
No, that's a good point. And I think it certainly, if we're going toward an operative strategy, it certainly should be included. So I guess I'm curious. Yeah, go ahead, Peter.
Well, if you believe Vinay-Badwar's data, it'll decrease your operative risk, right?
So it's funny you say that, Mark. We actually did that in Michigan as statewide, and it turned out that was the case. The cross clamp times were shorter, and the operative outcomes were better. And it turns out it's selection bias based on surgeon selection.
Absolutely.
Which surgeon is doing the operation? It's generally the mitral surgeons. So.
Exactly.
Yeah. So I guess MitraClip is not really a good option here, is it? I mean, with the calcium in the leaflet, etc. Because if you will still have MR after your first clip, it's hard to then put a second clip here.
Yeah, and I think that, again, this gets back to, and I agree with that, Peter, and just gets back to, and I guess I should have shown a non-color long axis view here. And essentially, when you have calcium riding up the leaflet, causing it to be fixed, the flail gap gets harder. And will the whole posterior annulus pull down so there's good coaptation without doing something in calcium? I think not.
No.
I think you need to fracture that somehow, maybe balloon it first and then clip it or something like that to get that annulus to hinge.
Yeah.
So I did not think that was a feasible option. So would anybody not operate? The STS is reasonable. This is a CABG repair, STS of 4, CABG replacement, STS of 6.
Everybody would.
I would operate.
Yeah.
We would operate. We'd think very carefully about it because the outcomes, with the star ratings are followed very closely with the mitral CABG. That's a high risk population, but we would end up operating, but we would discuss it over and over again in our conferences probably.
So Bill, that's important that you mentioned that. I mean, now this is a new thing, and maybe Mark can talk about this too, that the mitral star ratings are really new within the last couple of years. And part of the challenge with the CABG mitrals, it's just a smaller population. And so, one or two that don't do well can really skew your data. Mark, do you have any?
It's such a hodgepodge of things and the reason it's a hodgepodge is because if we said, okay, what's your outcomes for mitral valve repair? Well, no, very few people would have enough numbers that have any statistical significance. And so the powers that be piled everything together. Mitral valve replacement for endocarditis is included with a P2 prolapse in a 40-year-old marathon runner. And it's kind of difficult to interpret. And then CABG mitral gets thrown in there. Mitral maze gets thrown in there. Mitral tricuspid. Now, if you're doing a tricuspid for a patient who's got severe tricuspid regurgitation, they've got pulmonary hypertension. They're definitely sicker than a patient that's getting a mitral repair and sort of a prophylactic tricuspid repair, but there's no differentiation made. So it's a challenge.
Great. So I will show you what we did. And so, so soon after his admission, he was diuresed, and we ultimately decided to proceed with surgery. And he underwent a 3-vessel CABG. And we went in there with the goal, we're going to look at the valve, and if it's possible to repair, we would. Otherwise, we would end up replacing it. And just like Viv said, there's no harm in replacing. At the end of the day, you want a functioning valve, given this type of burden. And this is unfortunately not his case, but it's essentially exactly what we did. This was a case from a couple of years ago, but essentially detached the P2 and P3 annulus. And a lot of times I agree with Viv that you can sharply debride it. In his case, the calcium was tough enough, and I didn't want to get through the entire calcium and end up with the need for a patch that I ended up using a sonopet. And many of you, I think, have started to use the sonopet. It's an ultrasound that debrides the calcium, and it's become very helpful in these cases of severe MAC. We actually just presented our experience at Michigan using sonopet in about 20 patients for really big severe MAC and using it to debride the anus to put sutures in for replacement, and really showing it can help with decreasing the risk in that patient population. So in this particular case, I also used it just to debride the calcium enough, and it took all the calcium out of the leaflet again to allow the annulus to hinge. The other part of it is that for me that determines if it's repairable or not is once you take the calcium off the leaflet, how much residual leaflet do you have between the remaining leaflet and the edge, the free edge? And if that's very foreshortened, then I think then that's what ends up shifting me more towards a replacement. But in this case, as you saw in the echo, there was a lot of posterior leaflet. And even though we took about half of it out, half of the body of the leaflet out that was calcified, there was still a fair amount residual left.
Gore, this is a big operation.
It is.
There might be some junior people watching who, really should not embark on this unless they've got some experience. But can you just give us your approach? What did you do first? What did you do second?
No, that's great. So first thing I always do is I expose the mitral valve. So I put my annular sutures in. And whether that's a minimally invasive or an open, that's the same technique I use. So I can really start looking at the valve. I end up using a valve tester, which is actually a suction irrigator. And this is something that I think a lot of the minimally invasive surgeons have learned over the years. And use that. And a little technical, subtle thing is I actually use cardioplegia in that tester, as opposed to using saline that ends up washing your cardioplegia out. So in any case, that way, if I test, no matter how much I test, I'm not worried about, I'm still protecting the heart. So then I start identifying, where's the calcium. And in this case, it was clear it was around P2 to P3. And then I took a sharp knife and essentially cut the posterior annulus, cut the valve off the posterior annulus, maybe with a millimeter rim, and decide then, do you take it off sharply? Or in this case, I decided to use a sonopet because the calcium was really burrowed into the muscle. I didn't want to take all of it out. That's I think we've all seen the Tyrone David video from years ago where he takes a blade, a 10 blade, and cuts it out. And then you're looking at fat outside the heart. And then, he sutures it all shut. That scares me.
Or circumflex artery.
What's that? Or the circumflex artery.
Circumflex artery.
Yep. And that's what scares me. I haven't been that aggressive. So to me, using a sonopet is I think safer in that way. And then once that's done, then I reattach the posterior annulus, and now it becomes essentially a normal P2 prolapse, however you want to treat it. And the way I do that is I use a 4.0 Gore-Tex, and I run 2 layers from the ends and meet them in the middle for this detached posterior P2, P3 segment.
Yep.
When you use the sonopet, are you trying to get every morsel of calcium, or you're just kind of making it a smooth area? So
it depends on the scenario. For replacement, I'm just getting enough so that it's relatively smooth. There's no big chunks of calcium, and something that I can still hold my sutures. And of course, it's going to be large enough to fit your valve. So I'm always checking if there's mitral stenosis. You're always checking with your valve sizer. Am I going to be able to fit it in appropriately, and just taking enough that you can fit a valve in. In this scenario, my main goal was to debride enough calcium, take all the calcium off the leaflet, and also take enough calcium off the annulus so that I could reattach the leaflet. Other than that, I didn't care.
Great case. Yeah, great. Thanks very much, Gaurav. Excellent case. I think we have to wrap up because you have your echo for the result.
Yeah, this is the post echo. You see there's some mild residual MR, but compared to what he had before, he did well. We stayed a few more days for diuresis, but he had an echo at discharge, and that looked good.
Excellent.
Great case.
Great case. Yeah, absolutely. Fascinating. Thank you very much, Bill and Gaurav. Excellent cases for our hallway discussion. We're going to wrap up this session because we're going to record another one. And so we hope that people will also watch that next discussion that we will have with Mark Moon and Viv Rao. And so thank you all very much for watching. Thanks very much for the discussion that we had here on these 2 cases. And thank you all very much for watching this episode. And we go to the next one. Thank you.
Thank you.
Thanks.